Hello and welcome to Sarah Clinical Education's Oncology podcast. I'm your host, Kendall Schick. Today's episode features Deborah Wong, MD PhD, from University of California, Los Angeles in Los Angeles, California, and Aarti Bhatia, MD MPH, from the Yale Cancer Center in New Haven, Connecticut. Today, they'll be discussing current and emerging treatments for head and neck cancers as well as key clinical trials. This episode is part of a larger educational program titled Next Generation Strategies in HNSCC, Expert Insights on Breakthrough Treatment Innovations. For more information on our guests, along with a link to the educational program, please visit the show notes for this episode. Now, let's get started and hear what the experts have to say.
My name is Aarti Bhatia. I'm a medical oncologist at Yale. I have with me my esteemed colleague, Dr. Wong from UCLA. We're going to be really talking about the current standard of care in treatment of head and neck cancers, both primarily recurrent metastatic, but also kind of delving into some recent changes that we're seeing with treatment of locally advanced disease. And then we'll also talk about some exciting new therapies that are on the horizon and some trials that are investigating these agents. Many of these are in the late phase and phase 3 now. So, Dr. Wong, let me start off by asking you, how do you currently manage your patients with recurrent metastatic disease? How do you see their treatment paradigm in first line, second line? Feel free to elaborate based on HPV status or whatever other biomarkers you think are important here.
Yeah, thanks so much, Dr. Bhatia. I'm Dr. Deborah Wong, a medical oncologist at UCLA, and I have to say, and I'm sure you agree, Dr. Bhatia, it's really exciting times these days for patients and providers of patients with head and neck cancer. I think in the setting of recurrent and metastatic head and neck cancer, I think really the field has changed, I would say, in the last decade or so now with the incorporation of anti-PD-1 immunotherapy in the frontline recurrent and metastatic setting. We are now seeing exciting practice-changing incorporation of anti-PD-1 immunotherapies in the perioperative space as well. And so, but back to your question as to how do I manage patients with recurrent and metastatic head and neck squamous cell carcinoma? Um, for these patients right now, we are treatment decisions, standard of care treatment decisions are really predicated on PDL1 CPS score, program death ligand 1 combined positive score. Here, this helps us to prioritize pembrolizumab, how we're going to use primarily immunotherapy in that space. So for patients who have a PD-L1 CPS score of 1 or higher, pembrolizumab monotherapy is something that I will treat patients with. Certainly, if patients have a higher CPS score of 20 or higher, I may be more inclined to use pembrolizumab monotherapy. For patients who have bulkier disease or who have a lower CPS score, standard of care, I generally use chemotherapy plus immunotherapy. But I think it's important to note that these standard of care treatments really we're thinking about them in all patients. We know that head and neck cancer, squamous cell head and neck cancers behave differently depending on other factors, including things like HPV relatedness and things like that. So I think some of the exciting things that we're seeing, both in later line but also moving to the frontline setting, are emerging data and research looking at novel combinations, but distinguishing treatments based not just on PDL1 status, but based on things like HPV status. And so, but standard of care is pembrolizumab or pembrolizumab plus platinum-based chemotherapy. What about for you, Dr. Bhatia?
Yeah, no, I completely agree. I think, of course, prognosis matters and is different based on HPV status, like you mentioned. So HPV positive patients tend to live longer, tend to have more treatment responsive disease. I think we see some of our worst prognosis is associated with bulky, local, regionally recurrent HPV negative tumors. And for these patients, we know their median overall survival is on the lower side. It's about a year. And that's where we really need new paradigms, new treatment options, newer drugs to improve their cure outcomes at the time of locally advanced disease and to give us better longevity, better duration of response, and better overall survival in the recurrent metastatic space. So I agree with your management. We follow a very typical and similar pattern of treatment with either pembrolizumab monotherapy or in combination with chemotherapy based on PD-L1 status and tumor bulk. Of course, an exciting development has been our ability to offer now pembrolizumab in the perioperative space, like you hinted at. So two key trials, Keynote 689 and NEVO post-op, both showed that adding immunotherapy to perioperative treatment seems to improve 3-year disease-free survival, 3-year event-free survival. Those were the endpoints on those trials. So in the United States, immunotherapy, pembrolizumab in particular, has been approved by the FDA. So any patient with stage 3 up to 4A, locally advanced, especially HPV-negative head and neck cancers that are being planned for surgery, we are now offering 2 cycles of preoperative pembrolizumab to if their PD-L1 CPS is 1 or higher. And then the pembrolizumab continues in the postoperative stage with radiation, with or without chemotherapy, based on the pathologic risk stratification. And then pembrolizumab continues for up to 1 year. That's what the Keynote 689 trial demonstrated too, that these patients who got the pembrolizumab had improved event-free survival at 3 years. To your point, patients, about 40%, will still have recurrence or metastases and will need better treatment options in the recurrent metastatic space. So again, these are patients who are poor prognosis, especially the HPV negative. What do you think are some of the upcoming exciting treatments that we're starting to see in early phase trial and hopefully will be replicated in late phase trials too?
Yeah, that's a great question. I will say that in the perioperative space, our management for surgically resectable patients is quite similar. I think it introduces a lot of new and exciting challenges with regard to workflow and incorporating immunotherapies into the perioperative space. But hopefully, with with the incorporation of anti-PD-1 immunotherapy in the curative setting, we are able to cure patients with fewer patients relapsing. However, of course, we know that in the setting of relapse, patients still need good treatment options. And so, in that regard, I think thinking about HPV negative disease, and we know that these are patients who have the worst prognosis, as you mentioned, really exciting data have emerged, really looking at anti EGFR targeting strategies. And this is really built on data evaluating cetuximab in combination with pembrolizumab or nivolumab in several studies that demonstrated that the combination, particularly in HPV negative patients, really improved outcomes in terms of response rate and progression free survival compared to historical controls with pembrolizumab. And so now there are several newer generation anti-EGFR antibodies and targeted approaches that are being incorporated, all of which have been very, very exciting, particularly for HPV negative patients. And so some of the ones that for which we have emerging early data and that have now moved into late phase trials include bifunctional antibodies. So one example is Ficerafusp alpha or BCA101, which is being evaluated in combination with pembrolizumab. In the phase 1 study, the objective response rate was 54%. And the really exciting thing is that not just was progression-free survival good, but median duration of response was about 21 months. And the median overall survival from this early phase study was nearly 22 months. We put that in perspective with what we know about survival for pembrolizumab monotherapy or pembrolizumab even with chemotherapy from Keynote 048, where median overall survival there is only is 13 months for all comers, but if you look at the HPV-negative patients with pembrolizumab monotherapy, overall survival is much more modest. Here, potentially, we're seeing a significant improvement in outcomes. This is only one example. I think petosemtamab is the second agent. That's a bispecific antibody targeting EGFR and LGR5. And petosemtamab as monotherapy has shown very exciting response rate data. This is post platinum and post PD-1 in many cases. And so, similarly, this has now given rise to ongoing phase 3 trials, both in the frontline and second line setting. And of course, a third bispecific antibody is the amivantamab, which you may be familiar with from lung cancer, but this is the EGFR-c-MET antibody in which and they have an ongoing study with multiple different cohorts, but amivantamab as a single agent in the post-platinum, post-PD-1 setting had very impressive responses of about 40% or so as well. And so 3 different examples of strategies, novel strategies targeting EGFR that really are exciting in this space and have now moved into frontline setting as well. And what about your thoughts, Dr. Bhatia?
No, I completely agree. I think all these agents have generated a lot of excitement with their early phase data. Like you mentioned, their phase 3 trials are enrolling slightly different patient populations. So I think it's important to kind of note that, because based on the kind of patient you see, one trial might be better suited than another. And then petosemtamab is in both frontline and in late line, so second and third line treatment option. In the first line, that's the Liger Head and Neck 1 trial. It's a randomized design again, pembrolizumab monotherapy versus pembrolizumab and petosemtamab given in combination. The trial allows HPV-positive patients to enroll as well. And then in late line, patients should have progressed on both anti-PD-1 therapy and platinum-based chemotherapy, randomized to petosemtamab or investigator's choice systemic therapy, which can be cetuximab or 5-FU or a taxane. Again, both HPV positive and negative patients are being enrolled. And then amivantamab in phase 3, Origami 5, that's a slightly different design. It's randomized phase 3 in first line only, allows all PD-L1 expressing patients. So the petosemtamab and Pfizer trials allow just PD-L1 CPS1 or higher, but with Origami 5, they allow any PD-L1 expression, and that's because their control arm is pembrolizumab and platinum doublet, an FDA-approved regimen for first-line recurrent metastatic treatment. So hopefully you can enroll your patients to one of these 3 options. It might offer them the added benefit of a dual targeting EGFR agent, hopefully fewer toxicities, better response rates, and hopefully improved overall survival. So always very exciting times, I think, after a long time where we have so many different agents on the horizon, especially for HPV-negative patients.
A lot of the exciting studies are really focused on the frontline setting with anti-EGFR targeting strategies. But what are you excited about in the second line and third line space for these HPV-negative patients?
Yeah, absolutely. So there is an ongoing phase 3 trial. It's called the Fierce Head and Neck. We all know, like in the second line space, beyond progression on immune checkpoint therapy and chemotherapy, really our go-to standard of care for HPV-negative patients is cetuximab. And this trial is a randomized design. It's exploring the combination of cetuximab and ficlatuzumab, which is a c-MET, HGF-c-MET pathway targeting monoclonal antibody. And the control arm is cetuximab alone. So initially, I think the trial was exploring 2 different dose levels of ficlatuzumab in combination with cetuximab. They've narrowed down to the more effective dose, which is the higher dose, and is now that combination is now being compared head to head with cetuximab alone. They had a phase 2 trial which explored a similar randomized design of the combination of 2 agents versus ficlatuzumab. The ficlatuzumab arm closed early, but then the combination of the 2 agents showed a 38% response rate in HPV negative, which I consider very exciting. Again, if you think about cetuximab in this space. And then you mentioned in other second-line trials, I think there's a lot of exciting antibody drug conjugates on the horizon now. So a couple that come to mind are CRB-701. It's a Nectin-4 targeting next generation antibody drug conjugate. It was explored in both HPV-positive and negative patients who had no standard of care treatment options. And they presented results from 2 dose levels at ESMO last year, and the response rates were 33% and 47% for the higher dose level. I think the common side effects that you expect with these antibody drug conjugates can be keratitis, which was seen with this agent as well. You can also expect to see some neuropathy, maybe cytopenias, because the payload is vedotin, so it is a microtubule inhibitor. And then similarly, there is a ROR2 targeting antibody drug conjugate that's ozuriftamab vedotin. Those updated results were recently presented at the Head and Neck Conference in February. And they're looking to explore that, I think, mainly in the oropharynx cancer population. Their initial objective response rate was 45% in 11 patients. So that is also going to be interesting to look at as they move into hopefully phase 3 soon.
Yeah, I agree with you. In the second line space, lots of excitement and around antibody drug conjugate. And nice to see that, at least with the ROR2 ADC, we're perhaps starting to think about tailoring therapies based on not just what the patients have been previously exposed to, PD-L1 status, but now maybe even HPV status. So maybe moving towards in an era where we're thinking about treatments based on disease biology more. What about in the frontline space for HPV positive disease?
Yes, there are a couple HPV-16 specific therapeutic vaccines which contain HPV-16 oncoprotein neoantigens, which are expected to improve responses to immune checkpoint therapy. And 2 such vaccines come to mind. There is the PDS biotechnology vaccine in phase 2 trial data, which was a high response rate in patients with treatment naive HPV positive recurrent metastatic disease. These patients were treated with a combination of pembrolizumab and the PDS biotechnology vaccine. They're expecting to start enrolling into phase 3 pretty soon. Another vaccine is the BioNTech drug. It's BNT113, which is also in phase 3. Their lead-in data, their safety lead-in cohort had showed a response rate of about 40% in combination with pembrolizumab. And they currently are hopefully about to end soon enrollment to phase 3, where they're randomized. It's a randomized design for pembrolizumab versus pembrolizumab plus the HPV vaccine. So absolutely, I think we're starting to more and more, and for the first time, stratify treatment, not just based on PD-L1 status, but also based on HPV status. Because we've known for a while these diseases are biologically distinct, they behave differently, they respond to treatments differently, and hopefully we'll have more tailored treatment options for these patients in the future. Moving on a bit from the recurrent metastatic space now, there are some newer radiosensitizing agents as well that are in development. Unfortunately, the last agent that was looked at in this space, that was Xevinapant, encouraging results in phase 2, but then didn't quite hold up in phase 3. And there is a great unmet need for these patients, right? So we have cisplatin, but a lot of patients are not able to receive cisplatin. And we definitely need less toxic and more effective radiosensitizing agents for these patients. So are you aware of any interesting agents in this space? Anything you're excited about?
Yeah, I think most definitely. And not all patients are candidates for perioperative. They're not surgically resectable. And so, and even amongst that, as you pointed out, for the patients who only are left with definitive chemoradiation as a potentially curative option, not all of those patients will be candidates for the tried and true cisplatin. And so, really, standard of care options there would be radiation alone. In selected cases, we may consider cetuximab in combination with radiation. But we know that outcomes are not very good if we're not able to use cisplatin chemotherapy. And so, one exciting agent is an agent that really seeks to enhance the radiosensitivity of tumors. You mentioned
Xevinapant.
Xevinapant. And very exciting, however, didn't bear out in phase 3 studies. But we have another molecule, quite different and quite novel, J&J 1900, formerly known as NBTXR3, which is a radio enhancer. So essentially, it's composed of functionalized hafnium oxide nanoparticles. And these are administered as an intratumoral injection, both in the primary tumor as well as the involved lymph nodes, as a one-time dose and before start of radiation. And so there's an ongoing randomized phase 2-3 study in which patients who are ineligible for platinum-based chemotherapy can enroll on this study, and patients are randomized to either standard of care, which can be radiation alone or radiation with cetuximab, or standard of care plus this intratumoral injection. The idea being that injection incorporation of J&J 1900 will enhance the efficacy of a radiation for these patients. And so this is something that we've been very excited about. And patients are really excited about it as well, as it's a one-time procedure. They then proceed with their standard treatments, and the mechanism is just so cool and novel.
And, in theory, this could be scaled to any other tumor type as well that needs radiation treatment. So definitely stay tuned for that.
Dr. Body and me, let's say 5 years from now, hopefully the treatment landscape will look much different. What do you anticipate the treatment landscape will look like? And how would you think about sequencing treatment for your patients?
Yeah, great question. I would hope that we have an EGFR bispecific antibody that's approved in the next year or two. Hopefully, we have an HPV-16 specific vaccine that's approved around the same time point. I would, and presuming these results that we're seeing in early phase trials hold up in phase 3 as well, and these patients truly have a benefit in terms of response rate and overall survival, then of course, for an HPV negative patient, I might start treatment with an EGFR bispecific and pembrolizumab, as long as they're PD-L1 CPS positive. And beyond progression on that, we might have options like chemotherapy, which will be pushed to second line, of course. There's also hopefully an option of an antibody drug conjugate if one is approved by then. So, it offers us a few other options for these patients. If you have more than one EGFR bispecific approved, of course, that question is going to come up. How do you sequence an EGFR bispecific after another one? And I think, and this is a bit premature to know, of course, but because the second target of all these EGFR agents is different, maybe, after maybe sandwiching another systemic therapy like a chemotherapy or an antibody drug conjugate in second and third line, we may end up wanting to try another EGFR bispecific down the line.
Mhm.
So those, would be kind of how I sequence HPV negative patients. How do you foresee sequencing treatment for HPV positive patients?
Yeah, I think that's a great question. So, if I had my wish list, we'd have something like one of our vaccine studies that will read out positively. And so, for such patients, I would envision an HPV targeted strategy, perhaps a vaccine in combination with pembrolizumab for patients who are PD-L1 positive. And hopefully, at least the rationale is that if we can better interrogate the immune system, we're going to have very durable responses here. And hopefully, not very many of them will require additional therapies. But should they require additional therapies, then similar to what we have available, cytotoxic chemotherapy remains an option. and antibody drug conjugates, perhaps one specifically targeting or with activity in HPV positive patients, such as the ROR2 antibody drug conjugate. But I think overall, the strategies we have right now are really focused on patients with PDL1 CPS positive disease, which, based on the Keynote 48 data, comprises 85% of patients, but that still leaves a significant population of patients who would not be eligible for what's currently available in terms of a chemo-free regimen. So I think there's more to be done there. I think there's also a lot more to be done for patients in the curative intent setting who have locally advanced disease, but in particular those who aren't candidates for surgical resection. And so hopefully things like better agents in the curative intent setting, be they EGFR-targeted antibodies or vaccine type approaches, might also come to the fore. So that's going to further complicate, in a good way, the idea of treatment sequencing as well.
Thank you, Doctors Wong and Bhatia, and many thanks to you, our listeners, for joining us today. As a reminder, to view the full program, Next Generation Strategies and HNSCC Expert Insights on Breakthrough Treatment Innovations, please click the link in the show notes. And be sure to check back regularly for more episodes on important oncology topics.